listening to Rated RX. Your dose for the day.
Hey guys, Robbie Bossy here with Samuel Hill I said that wrong
Samuel
already.
Hill.
Samuel Hill with Samuel Lona
We're
and
starting
Xavier
great.
Hill. And you're listening to the Rated RX podcast, an affiliate with the Pharmacy Podcast Network. Guys, we're coming at you with the last episode of the year of 2025, and we want to end on a big note. Big news of 2025. So each of us has selected an article that we think is big news and we should be talking about and how it's going to affect healthcare.
Let's do it. Let's do it, Robbie.
All right. So for my news piece, and I'm actually very surprised this has not gotten enough coverage, but back on September 30th, this year, 2025, the Health and Human Services Agency released a blueprint for how AI is going to be used across the entire health systems that they have. It essentially talks about how they want to modernize how the federal health systems work without blowing up public trust in the process. I'll let you guys simmer on that one for a sec. The strategy opens up by saying AI is already here. They already did 270 AI projects this past year, and they plan to do about 70% more this year. So instead of letting every division of its own within the agency do whatever, they're trying to have one coordinated, responsible approach. This approach basically revolves around 5 pillars that they describe in this blueprint. Pillar number 1 is to ensure governance and risk management for public trust. I roll again. Sorry, I have some feelings about this. Anyways, yes, I have some feelings about this. So the agency wants strong oversight, as what they put it, real governance boards, inventories of every AI health system in use, testing before anything goes live, independent reviews, continuous monitoring, and the power to shut down any AI system that isn't safe or compliant. In short, they don't want to unleash an AI healthcare system unless they're ready to control it. Not afraid of that at all. Pillar number 2, they want to design infrastructure and platforms for user needs. They want to build what they call a one HHS AI integrated commons, which is basically a shared space where all the tools, data, and computing power for the AI is in one place. So every agency isn't out there reinventing the wheel. They explicitly say all the data has to follow what they call the FAIR principles, which is an acronym for findable, accessible, interoperable, and reusable. Pillar number 3 they describe in their blueprint is to promote workforce development and burden reduction for efficiency, which basically means that the agency acknowledges AI won't help anyone if they're using it in a way that they don't understand or don't understand how it works in general. So they want widespread training from leadership down to the frontline staff to reduce administrative burden. They're saying the tools should essentially fit the workers and not the other way around. Pillar number 4, foster health and research and reproducibility through gold standard science. The agency ties the whole strategy to, again, I roll here, gold standard science, which they imply anything AI touches from data analysis to research should be transparent, reproducible, and rigorous. And the last pillar, pillar number 5, they describe it as they want to ensure care and public health delivery and modernization for better outcomes. This is the part that everyone cares about. The strategy says AI's role in care and public health delivery should be outcomes first, meaning they're only interested in tools that clearly improve patient outcomes, population health, or service delivery. So the big takeaways of this article, when you take a step back and try to look at it to the big picture, is that they're saying AI is coming, it's here, and if they don't control it, coordinate it, and train people how to use it safely, they're going to have problems. To be clear, this is not a clinical playbook. This is not a product rollout. It's the federal government trying to create structure before AI gets ahead of them. And whether you're excited or nervous about it really depends on how much you trust the people writing the rules. So there was a lot to go over there. So discussion. And I want to hear you guys' thoughts here. What do you guys think AI's role is in healthcare?
So I kind of like, what they're doing, getting ahead of it and kind of come up with a plan for how to handle AI rollout. And I think they're going about it mostly in the right way. They want to use it as a tool to assist the current workforce, whatever their jobs may be. Ideally, make things more efficient, make things flow better, make things go a little bit faster, maybe. Um, so I like I kind of like some of the things that I'm hearing in this. But like you say, it has to be, done right, done correctly, right? They have to really have the right people behind it with good intentions and not try to control things too much, but also, like what I say, want to protect us, do a good job trying to keep it from harming us or our patients. So, yeah, I think they're on the right track using it as a tool for the employees and workforce.
But where do you think AI should be used in healthcare, though? Like, what is its place?
I don't know, like a specific place.
First thing that popped into me was like data research or like being able to pull specific things. It's like, yeah, I'm thinking of this thing, or these two side effects are crossing, or something's going on, and trying to be able to pull information to then, in our case, the pharmacist, or it'd be whoever is able to then go through that kind of abbreviated data or give ideas on where to go from there, just as speeding references or research, essentially, in an individual quick thing.
Yeah, I would definitely agree with you, Sam. I think AI's place right now, especially, is in data analysis because you can put in a bunch of stuff in at once and it can spit you out some equations, some statistics to do research. Of course, there's some rules you have to be careful about because HIPAA is always something of concern. So once you put it in the AI, it's stuck there. So you have to be careful. And also why I think it's very concerning about how much you use AI in healthcare because there obviously has to be a lot of encryption behind it. Just my own thoughts there. But bigger question here, and I'm sure you could tell from my sass and my snarkiness reading some of these points. Do you guys trust the federal government to manage AI safely? Why or why not?
I'd say it's going to be
Long pause.
hard. It's going to be
probably
hard for anyone to manage it. It doesn't matter
who it
what
is.
government, who's in there, what state, country. It's gonna be so big, so many avenues, so many apps that people can create to do their own AI, that it's gonna be pretty hard for anyone to really control it. So I mean, the government can say these things unless they have some ability to truly, affect the internet. Just think about it as the internet. Like, how well does a government control the internet? Can
That's
they
what I was
really
gonna
control
do.
it?
Yeah,
It's probably gonna be similar to that,
exactly.
where you can make some rules, you can have things that are blocked realistically. I don't see anyone being able to block or stop this. They're trying to guide it a little bit. Sounds like they're not really coming down with a hammer on shutting down AI, or can't have China AI must destroy. It's like it's just going to be there's no stopping it, is most likely.
Okay. What are your thoughts, Zay?
Yeah, I agree. I mean, it's hard to trust our government with the little things. I mean, with some of the things they do now, right? So definitely will be difficult to trust them with AI as well. Just because they've done bad things in the past, and if someone has showed you their hand, um, they, is capable of doing it again, right? So trust is probably not the best word because most people don't trust anyone because you never know what people are going to do to you or what the government is going to do to you or what they're going to do with AI. So yeah, it's just hard to fully trust anybody, but I do like that they're trying to not necessarily control it, but just manage it to where it's not like the wild wild west of AI.
I agree with you. There definitely needs to be rules in place so people aren't just doing all silly nilly online. I think my concerns here is the article says it wants to follow gold standard science, right? Um, so if the federal government is deciding what is gold standard science, and they already have a history of going against gold standard science, and now you're using this AI system that they're telling you this is what you have to do to make your clinical decisions, and they're deciding what gold standard science is when they haven't been following the scientific process to begin with. That is concerning. And I think that is going to largely affect patient outcomes. They're not going to get the best ones possible. Moreover, the thing is, like, when it comes to helping people, what separates pharmacists, physicians, nurses from what AI can do is the clinical thinking and the reasoning. Like, the AI can spit out data, but it's not going to be able to rationalize, like, oh, this person has XYZ going on at home too, all these other factors going on in their life. Like, AI is not going to know that. It doesn't have any empathy. It's programmed to
Not
say
yet.
something. Yeah, not yet. But the thing is, like, AI is programmed to say something. So if you are relying on what it is telling you, you kind of have to be very skeptical about the information you're getting, especially when the people writing the rules and saying what the validated information is kind of questionable when it comes to healthcare and science right now. So
It's
I
gonna be
have
like
concerns.
Demolition Man. You guys know that Wesley Snipes?
Yeah.
And
I don't.
ring a
never
bell.
watched
So it's like it goes into the future, but essentially they all have like these little computers, and they speak into it or tell it what's happening. So it's like cops. And they're like, "There's an assailant here, and he's agitated," and it tells them what to say. It's like, walk up and say, "Do this or else," and so it like walks them through everything to do.
I have to catch
But,
that movie.
It's
What's it called again?
good.
Demolition Man.
Demolition Man. Okay. All right. I'm gonna catch it.
Yeah, watch it this weekend.
All right. All right.
It's
I'll
a
watch
classic.
it. All right. Demolition Man.
But that's what it made me think of with your kind of basic or following an AI of just putting in input and doing whatever it says.
Yeah. Yeah. So I have concerns. So we'll see how this pans out. Well, that is my pick for big news of 2025. I'm Robbie Bossi with Xavier Lona. Just kidding. With Xavier Hill and Sam Lona signing off. Thank you. Thank you very much.
All right, guys, we'll move over to the next segment. This is the Rated RX podcast, affiliate of the Pharmacy Podcast Network. I'm here today with Robbie Abassi and Sam Lona. And today we're talking about things in 2025, big articles in 2025 or changes in 2025 that, had a little bit of bang. And we want to talk about it and discuss some of these things before the year ends in our final episode. Just know we're live on YouTube. Shout out to everyone out there. How y'all doing? I hope you guys are going to enjoy sitting with us. So
we go.
my segment, I titled it, When Vaccine Policy Changes, Who Pays the Price? Okay.
Ooh.
So that title is based off the recent recommendations to roll back the universal hepatitis B shot at birth. And I also want to talk a little bit about why many public health experts say that this could possibly be a dangerous shift. So when you first heard that ACIP, which is the organization that makes the vaccination recommendations, was moving away from universal newborn hepatitis B vaccination at birth, what was your first reaction, guys?
Here we go.
I was very, very shocked because I don't know how much you guys have been following the whole politics stuff in general. I follow it a lot. Disclaimer: I'm a registered independent because I hate both sides, so I like to think objectively here instead of join the bandwagon. But I can't remember what the senator's name, but he basically voted RFK Jr. in with the premise that he would not roll back this vaccine recommendation. And he was the deciding vote. And he was promised up and down. And so my thoughts is that holy shit, we elected a liar. So that's my thoughts.
But aren't all politicians liars?
For sure. What's that old saying? It's you can tell a politician's lying where their lips are moving. So
Sam,
but
go
for
ahead.
real, it is scary and concerning. We're not going to see these effects of this recommendation rollback till way later in life. Kids are going to be missed. There's going to be higher rates of hepatitis, and unfortunately, there's only going to be victims from this choice.
Yeah, I think
Sam?
it's going to hurt kids. I mean, is the bottom line. It's going to hurt the population by rolling these back. These got in place, like ranging years ago to, different things, but people now don't really see those interactions, experiences, what happens when before vaccines, what it was like in a healthcare setting. And I think we've been very fortunate to have these. And so I think when these policies are coming in like this and things are changing, that in this case, kids are going to be hurt by it. And there's going to be long-term effects. Who knows if this keeps rolling out and it rolls over to a bunch of other things on those changes and how long it takes. But it's not politics. And as you're saying, it's science. Like these are here for a reason. It's not having to do with your affiliation of your party or even your country, being U.S. Like this is to help people, and it's gonna be tough. It's gonna suck for a number of people.
And just piggybacking off that, going over some of the possible things that can happen. So just thinking about it, this change happened recently. This was December 2025. They voted to change this recommendation. Some people voted against it, but majority voted for it. But the recommendation was that if the infants who are born to mothers who test negative for hepatitis B, they no longer automatically have to get the vaccine at birth. Instead, it's now individual-based decision, right? Meaning the parent can delay the first dose for up to 2 months later. So they still have to get the dose to follow the vaccine schedule, but the parent has the option to wait a little bit after birth, like not right away, and delay that a little bit. So, I mean, for some parents, they like, dang, as soon as the baby get out the womb, give them a shot. So they're like, oh, can we just wait a couple days? Some people might like this, wait a couple days and then get the shot. But you can wait up to 2 months with this. But if you delay it, the newborn is at risk for a lot of things. And these are some of the side effects that Sam was talking about, things that can get us into trouble, right? The newborns can get hepatitis B through birth exposure if they don't get it right away. So they can have it, coming out of the birth canal. If they didn't test the mother properly and they didn't know she was Hep B negative, ideally, they would test that beforehand. But, let's say, the parent just came in for emergency C-section, they can get to check all that. They can get it from household contacts, so other family members who may have been exposed to hepatitis B. They can get it from caregivers who may be in your home taking care of other family members. They can get it from contaminated blood or body fluids. A lot of that's going around in the hospital. And then other rare, medical errors that can possibly happen. So, I mean, it increases their chances of getting it. Maybe not a lot, but hey, any increase is too much, right? But the scary part is if a newborn gets hepatitis B, there's a 90% chance that they develop a chronic lifelong infection with hepatitis B. It's a pretty high chance. 90%, that's an A, right? So you have a high chance of having a lifelong infection. And that can lead to cirrhosis, which is terrible damage to your liver, right? Liver cancer, and a lifetime of complications. So rolling back a universal newborn vaccine could lead to a lot of preventable infections and issues that we could have stopped, right? That's why we created vaccines, to stop something that's preventable. Piggybacking off that, do you guys think the public realizes how much this political ideology and these political changes are starting to influence medical recommendations. You think the public understands what's happening? Because the healthcare profession, you see a lot of people posting on YouTube and TikTok and Twitter, kind of outraged by this. But do you think the public understands this?
I think it depends on the person, and and I think we live in the side where we see the consequences of it. But I've seen, and I don't know if you guys have seen. There's another Dr. Mike, also a social media influencer. Great content. Shout out to Dr. Mike. I know these people exist who want less recommendations because he'll actually have debates against them. These people who want RFK Jr. to do more. So these people exist. So I do think people do know, but I don't think they understand the real consequences of what it's doing.
I'd probably agree about that. It's probably for a number of people comes down to like a an us versus them mentality, and that's tough when it comes to protocols and healthcare because you you think you're on the right side. You think you're making decisions for the right reasons, and we're trying to look objectively here on the science side and healthcare, and in this case kids. We're talking about newborns, kids, lifelong cirrhosis disease, serious thing they got to live with and deal with. That it's going to be, as I said earlier, it's going to be tough for them and for families, and it's by the time you figure this out and that individual family interacts with this or has ends up being on the wrong side of this, it's going to be too late for them. And how many of those have to happen before this changes? So, in this case, we're talking about a couple months. I'm sure at some point, I guess I didn't read, and maybe you guys know if there was a clinical reasoning between 0 and 60 days or 0 and 90 days on why they're choosing these time points for them that is guiding a policy change like this when it should be clinical based, and how much is that going to change on other things that were originally clinical based and might get moved into some sort of political change for that, then it's going to cost your patients down the road.
Yeah. So what does this mean for parents out there? Like, Sam, you and I may be having kids in the future. Robbie, you may want another kid. What would you say, to a parent who's on the fence and thinking, well, if the birth dose, if the birth dose isn't required, maybe it's not that important.
Yeah, that's tough to address because I could see why they would think that. Like, it's not required, so do I really need it at all, right? And I think why this is concerning in my eyes is, yeah, you have 2 months to go get the shot, but a lot happens when you have a newborn, like, sometimes you miss appointments depending on the mother's birth. Postpartum hits hard. And
Mhm.
so it doesn't make sense to do it later when you don't know what their life is going to look like in 2 months. Like, a lot freaking happens in that 2 months.
Mm.
So as a parent, I can tell you it was all a blur. It was all a blur. I tried my best. And as a newborn parent, I did rely a lot on what the doctor said because, like, yes, I'm a pharmacist, but I'm also oh, trying to figure it all out. And also, because I was a pharmacist, I knew better and I knew to follow these recommendations when I did it. But it is concerning because I don't think the average person knows, in a sense of like, is this urgent? So I don't know. It's concerning. It's concerning.
And I think Robbie brings up a good point about what we're making these assumptions with these policies on the mother, the family, the newborn will be back at 2 months, at
Mhm.
6 months, at I don't know what the standard protocol is, but all those checkpoints that they'll be back. And what data separately to this, what's the data on how many of those appointments are made across the US or the world for that matter. Really we're talking the US here.
Yeah.
But I remember in school talking about mothers that were pregnant, and they had, protocols leading up, and there was the little asterisks on there. It's like, what is this? What are they talking about on changing this protocol? And it's pretty much, it's like, oh, we don't think this mom is going to be coming back again before pregnancy, or they've already told us. It's like, hey, this is my only appointment before we're going to have the baby. And so it's there are times when, yeah, it's recognized we're not going to be able to follow those time points for them, to come in. So yeah, how many parents are completely fine with, okay, yeah, let's do the 2 month, and then what Robbie's saying, oh, we got busy, something happened, or we got COVID, couldn't make it in. It ended up being 3 months, 4 months. They come back at 6 months. Now that newborn is 6 months, having that kind of assured time point at birth that they're getting that vaccine for them.
Yeah. Yeah. Great point, Sam. I mean, it can lead to confusion, which can lead to missed doses, which can delay immunity and increase infection rates, which is that we don't want that. So, wrapping up, you guys do some more research and figure out the best thing for you as a parent. We recommend, getting the vaccine right away to prevent you from having to worry about coming back 2 months. And that'll be it for this segment. Thank you guys for listening in. I hope you learned something new. Make sure you follow us on YouTube, social media, all the social, Instagram, all the socials. Tune into our lives. We're starting live, starting now. So yeah, check back with us, and we're out.
All right, let me take over for you then. This is Sam with the Rated RX podcast, here with Robbie and Xavier, in affiliation with the Pharmacy Podcast Network, and continuing on our subject here, ending the year for big changes, big things that have happened in 2025. And so for me, I'm talking GLP-1s, and a kind of a leading off with an article and then kind of circling back to it kind of over the years. But there is a company here, Wave Life Sciences, announced, and this was just a couple days ago, so still here in December, of their phase 1 clinical trial of a med they're currently calling WVE 007. So we got a 007 med here that is a single dose kind of GLP-1 or similar to GLP-1 agonist that is a once every 90-day dosing currently. So they do a single dosing for this, and the results on this are essentially showing that it has a reduction of both baseline visceral fat, total body fat, and an increase in lean muscle mass. So it's pretty much the first one that is actually increasing muscle mass with it, which is a big difference between everything else that's been going on there. And so this is still phase 1, and for those listening, that means this is going to be years away, if ever, that this comes out. But realizing that it could be a shift in this GLP-1. So kind of looking over the progress of that, and we circle back to meds in general. I remember being in pharmacy school, and in our usually a third or fourth year, having to do a report on a med, and it was semaglutide, and it had just come out in the injectable. At this time, it was just for diabetes, and it was once weekly dosing instead of once daily. It dropped the side effects some, and that was kind of the big thing, that it had a little bit better side effect profile, and that was kind of it was kind of cool, but that was kind of it. And then fast forward now, COVID, the GLP-1's just blowing up, and that kind of market demand that's had kind of taken us over, and I know you guys have seen it too. I know Robbie talking about, maybe even adding it into psych patient protocols with having a lot of weight gain issues with other meds, something that you've thought would be pretty advantageous to patients. But now everybody knows about it. It's on social media, wellness, celebrities is where pretty much first kind of really blew up. And then, pharmacy shortages, compounding came in for a couple of years after COVID, and kind of part of that when there were shortages. And, me being a compounding pharmacist, we didn't start out with that for quite a while, but just continually got requests for it over and over, and finally looked into it. It's like, okay, we'll start doing this, and it just continues to blow up. And with those, we've seen the introduction of then tirzepatide on top of the semaglutide, and those being injectables, and still having shortage issues with those. Running into FDA, also kind of not knowing what to do, kind of putting out warnings in there what to do, but they're not stopping it, and they're recognizing those shortages, and then continuing across those. Zay and the VA, were you seeing more people on that, or more people discussions on that? I know you're a little older population,
Oh
but
yeah.
was that still coming up?
Yeah, they're still using it. I know we do a lot of the bariatric surgeries at our hospital. A lot of people from other VAs come to our VA for bariatric surgery, but I'm starting to see a lot more patients on GLP-1s. And when they come in, we gotta like, okay, what day of the week do you take your dose? And we gotta try to make sure we continue giving it at the same time frame, unless they're like super sick, then we just hold off on it. But and then we also send a lot of people, with side effects, people who taking GLP-1s, without a doctor, they get it from a friend or something, and they getting a lot of nausea and vomiting and coming to the hospital from the side effects. They're taking doses too high because they see the celebrities all skinny and beautiful, and, they're copying after them. So the craze is still wild.
Mm-hmm. For sure. And then, circling back to the newer meds, so things that are still investigational at the moment. Retatrutide is one of the newer ones. It's a phase 3 right now, but also an injectable. But it's essentially showing a little bit more weight loss than tirzepatide. So we're like in the mid 20s. Zay, you seem to get all excited when I said that word. Is that something you remember in your bingo card?
No, no. So I'm on X. I do a lot of investing and stuff with X, but there are some people on X that they're getting this tide supplement from somewhere. They're buying it from somewhere, and they're talking about how it's helping them lose weight and gain muscle strength. So people are buying this now before
Mm-hmm.
it's even approved, and they're using it. Like
Yep.
I was like, what?
Yep.
I was like,
We
I'm a
get questions
pharmacist.
for
I
it.
haven't even heard of this, but
We can actually buy the powder, so we could compound it. It's not FDA approved yet, still in phase 3. So a lot of that things are still not for human use, or for research only kind of things. So I'm not sure specifically where people are getting it. We've had prescribers ask us about it, and it's like, I mean, we could get it. It's way more expensive at current what we can get, but it's not on an approved list. Like, we're not going to compound this for you, but I could see it on being able to order the powder. But
and I'm sorry, I was just gonna
but
say,
yeah,
but
people are getting it, and they're doing all sorts of things. So we can touch on that a little bit when we talk about kind of pricing of these things. But
mm,
how much are people just wanting the lowest price and not worried about what they're getting, just results, and how much is it just a scam of buying something online? That's no script. It's like, yeah, you're probably not getting the real thing there. But another one moving on is oral use. So all these have been injectable. So I was kind of curious on if you guys have had any experience or thought of this opening up into your practices, of having people want an oral version. But the orforglipperon is currently, you're just finished or just finishing up a phase 3. So I'm guessing, I think they're saying maybe in the next year or so, from Eli Lilly, that this one's going to be coming out. But it's a once daily tablet. These are non-peptides, so it's a much smaller molecule.
mm,
So ideally, it makes it easier to manufacture. So potentially some lower price points on this. Also, because of the smaller molecule, makes it so, with or without food, any time of the day, where semaglutide oral, had to be on an empty stomach, bigger molecule, a peptide, it's a little harder to absorb, a little more issues there. So hopefully, It is something that comes on. If I pull up here Eli Lilly's info, they're showing that it is the plan to file for the weight loss side of it by late 2025, and then following that with the diabetes. So they're actually looking to push out a weight loss version first, followed by diabetes version. So it kind of shows you, what they're pointing to, or where that side is pushing from. But with those, little less weight loss results. So we're looking at low 10%, low teens versus the injectables are in the low 20s for that. But it is an oral version. So bringing that back to you guys, do you think you've got patients that would want this oral version, or that injectable has been something that's they've been afraid of and not wanting to do versus a daily tablet?
Well, my setting is a little unique because we try to avoid injectables in acute psychiatric setting. So we prefer orals, but we face different challenges, and it's not that they don't want to take the medication. Well, sometimes it is. It's a psych setting, so let's be real. But it's not because of a lack of trying. It's more of a lack of insurance coverage. Our setting, we try to follow the Medi-Cal formulary, and Medi-Cal for a while was covering this medication, Rybelsus specifically, but we just got a letter saying they're going to stop covering it and we can't use it anymore. So now we're sort of at a loss, like, oh crap, what are we going to do? Because half our patients already come overweight and we can't use metformin. That's not going to do anything. And so we're sort of at a loss right now because it's like, we can't give them an injectable. Like, that's just going to be too hard to coordinate, and we're not going to discharge them with an injectable. But the insurance won't cover the mismedication. So we're in this kind of crappy limbo right now. And I wish we had an answer. I really do.
So looking on Eli Lilly's webpage for Lilly Direct, they're projecting that for their oral version, their starting doses will be at 149 and higher doses going up to 399. So I'm guessing that's going to be per month. So do we feel that that's a reasonable price, or we're still going to be missing the mark that these patients that we're trying to get cash pay, this is still way too much for them?
Still
a
way
little
too
pricey.
much.
Yeah.
I mean, that's still way more expensive than going down to Mexico and picking up Rybelsus. That's crazy to me that, like, we're all excited about this because it's like a point of reference, right? Like, oh my God, it's cheaper than what we know, but it's like, it's still cheaper across the border. So that's
Yeah,
what
and
doesn't make any sense.
I get people calling me about things like this and like that low end price point, and it's like, but you got to realize, like, okay, that's for the first month, and then you start moving your dose up. Like, when you're on this, your price point's going to be up at that $399. You're not, people see that 149, or for the tirzepatide, I think Eli Lilly or the ones that were on there were like 189 in a starting dose or something like that. It's like, that's just your first month, and then you just start going up. So you need to realize when they give you this range, they're currently saying 149 to 399. Your true monthly cost is going to be up in that $350 to $400. That's what you're going to be paying. You're not paying 149. That's going to go away quick, and I think that's part of that people have a hard time. And that's a lot of money. Like, yeah, they're trying to cut it down. They're a third, a quarter of what it was. That's still going to be a lot of people. That this whole point of cash pay of those that can't afford it, that's still a lot for them. Zay, you had something to say?
I mean, it just feels like a scam. Weight loss drugs. It feels like a scam. Like, it's like, once you start taking them, you gotta keep taking them. If you don't, if you to keep the weight off, right? Because you can get the weight back quickly if you stop it too fast, right, or something like that. It just feels like a scam, and then only the people that can afford it can get it, right? So the celebrities, all of them scaling good, but because they can afford to buy these drugs, so it feels like a scam.
But Xavier, you can say the same thing about blood pressure meds. Once you stop it, you rebound, right? So
Yeah.
I think you have to redefine the way you look at obesity, and that actually is a problem that healthcare providers have. They kind of do have this prejudice towards people who are overweight, and it
Mhm.
actually is well documented that overweight people tend to get worse care because of that attitude and mentality. So
That's true.
yeah, so you really do have to think about it as a disease because it is a disease, and we do have to treat it. And any other disease we would treat. So
I
I don't know. We have
I,
to
under,
redefine the way we look at it.
I understand. I mean, I just wish we would put more money and effort into preventing things and incentivizing exercise and making healthier foods for us, for the people. So that's all.
Me too, but here we are.
But that's not what the people want or care
Money
about.
rule
Is
the
the
world.
problem.
Yeah.
But so then we circle back to the new med, the WVE-007, that they're trying to check into it being a every 6-month dose or annual dose. So you could potentially be having a single injection that you go in once a year, and being still controlling at least some point uh, weight loss, retaining lean muscle mass, which is a big one because that's one of the biggest issues with the current ones. So, are we moving that way? Is this, even going to pass clinical trials? Because again, circling back to that phase 1, that means this drug is maybe 6 years, 10 years out that it could be hitting the market. Who knows what the landscape is then. They could be all in the crypto, with AI crypto, and be gone from that. So wouldn't even matter.
We'll have the time of day for us here.
What a time to be alive.
Mm-hmm. All right. Any final thoughts?
Obesity is a disease.
Please exercise and eat right if you can. Please.
Balance it out. All right. Well, please, as well, like and subscribe. Facebook, Instagram, the TikToks. We like it all, and appreciate any comments, questions. We'd love to interact with you guys. This is Sam with the Rated RX podcast, signing off.
Rated RX, you do